Welcome back, everybody, to Monday Explained. In this episode, we're going to be talking about Parkinson's disease. We're going to talk about what is it does it look like from a clinical perspective, pathology, a little bit about how to treat it, and kind of like the high yield points that you want to know for exams. Okay, first of all, Parkinson's is a neurodegenerative movement disorder. So what that means is you got loss of some sort of brain or spinal cord neuron problem, degeneration, and that causes for you to have some abnormal movements, right? Okay, so if you remember from our last video when we talked about the basal ganglia direct and indirect pathways, if you're not familiar with those, go check it out. They kind of help you get the picture of this. So what happens there is the substantia nigra, which is a part of the basal ganglia, the pars compacta specifically, that's why I started in purple right here, it becomes degenerated. And what happens when it becomes degenerated right here, right? You kind of lose the dopaminergic neurons there, and you lose a vital part of the basal ganglia. And you have a classic picture of a patient that has rigidity and like some odd movements that we'll go over in a little bit. But yeah, so the substantia nigra is a part of the midbrain. This is a midbrain slice that I kind of schematic that I drew out. And you actually see a degeneration of this line. This line is usually like kind of like a pigmented dark line that is supposed to signify dopaminergic, the substantia nigra, which is the dopaminergic neurons right here. And the pars compacta is degenerated and makes this line kind of less dark, and you see it degenerate away, and it kind of becomes pale rather than a nice dark line. You can search on Google a picture of the substantia nigra, and you'll see that it's nice and dark. And then you can say substantia nigra Parkinson's, and then you'll see that it's kind of paled away and the color is gone from it. And the etiology of this, we don't really know. Some people, there's been genes that have been identified that are related to Parkinson's. There's also medication-induced Parkinson's that some people have hypothesized, and but we don't 100% know exactly how it comes about, but we do know the classic picture of a person who has Parkinson's. So let's go over that. Okay, now for the pathology, what you see under a microscope is loss of dopaminergic neurons in the substantia nigra pars compacta, which we just went over. And you kind of see that on gross pathology, right? So if you look at a slice of the midbrain on someone who has Parkinson's, you'll see kind of depigmentation is what they call it of the substantia nigra. And you also have under a microscope Lewy bodies, right? So Lewy bodies are these aggregates of alpha-synuclein, and they are found inside of these neurons. And these are two really big points that you should remember for a test, because Lewy bodies, alpha-synuclein, you think of Parkinson's right away, or loss of dopaminergic neurons in the substantia nigra pars compacta. Now, a clinical picture of a patient that comes into your clinic will be a patient that is about 60 years old, the average age that someone has Parkinson's, an older male, and they have something called a pill rolling tremor. Now, this is kind of quote unquote, kind of like high yield to remember a pill rolling tremor. It's a tremor of the hand, and it doesn't really look like they're rolling pills in their hand, but this is what they call it. And you can easily look up a video on YouTube about that, as well as cogwheel rigidity. So they have this type of rigidity that's kind of like a cogwheel motion, and you could search that on Google as well. These two I highlighted because they are high yield, and you should know them for exams. When these come up with something called Lewy bodies, alpha-synuclein, you should be in, they're trying to put you towards the path of this is Parkinson's disease. And that would be two really easy ways of identifying this disorder. Now, two other parts of the clinical picture, you'll see slowed movements, also known as bradykinesia, and shuffling gait, kind of like a grandma in her slippers, like walking across the kitchen floor or something. She's shuffling along. That is shuffling gait. Now, as far as the treatment, what you're trying to do is raise the dopamine, because you're losing dopaminergic neurons, so you have less dopamine. You affect the basal ganglia, and what you're trying to do for the treatment of Parkinson's is increase the dopamine, because that's what's depleted. And you do that by giving a medication called Cinemet, but in exams you might see levodopa, carbidopa, and they're the exact same thing. Just Cinemet's usually what everybody else calls it. So levodopa, carbidopa is the treatment, and this is what you give a patient that has Parkinson's to increase the dopamine levels in their brain. The reason you don't give dopamine right away is because it doesn't cross the blood-brain barrier. So levodopa is a precursor to dopamine, and it'll cross the blood-brain barrier and then convert itself into dopa. Well, become converted into dopa. And they give carbidopa along with it because levodopa can be converted in the periphery as well, and you don't want that to happen. You want it to happen in the central nervous system where the pathology is going on. So carbidopa prevents the conversion of levodopa in the periphery. Now, one last tidbit that helps me remember Lewy bodies and alpha-synuclein is kind of like a little story that I tell myself. Is like, okay, so you go to the park for Parkinson's, okay? You go to the park and you see a guy sitting on a bench. His name is Louis. And Louis is trying to sell you some sketchy street drug called alpha-synuclein. Okay? So go to the park, see a guy on a bench named Louis. He's trying to sell you some alpha-synuclein. That's like a little weird way I remember things, but hopefully that helps. So if you guys have any questions, leave them in the comments below. And I'll see you in the next one.